everyone. In this episode, I interview Professor Adam Balen, consultant in reproductive medicine. We discuss the Polycystic Ovary Syndrome. I'm Dr. Gail Busby, and this is I Forgot to Ask the Doctor. Hi everyone, thank you for listening to my podcast. In this episode, I'm going to interview Professor Adam Balen about Polycystic Ovarian Syndrome, or PCOS. If you ask gynecologists in the UK which doctor they think of when they hear PCOS, Professor Balen's name would be the answer given by the vast majority. Adam is a professor in reproductive medicine and surgery. In addition to his work in fertility and IVF, he has a particular interest in PCOS and has published extensively on this subject and its effects in adolescence through to adulthood. I've personally heard him speak at many conferences, and I'm absolutely thrilled and honoured to have him here today. Adam, welcome. Thank you so much for agreeing to be interviewed on my podcast.
Well, thank you, Gail. It's a pleasure, and thanks for inviting me. Thank you. Yeah.
Adam, I always find it really interesting to know why high achievers such as yourself chose their particular area of medicine. What attracted you to fertility work, and in particular to PCOS?
Well, that's quite a long story, so just to keep it very brief, my pathway to reproductive medicine essentially started after I spent a year working in an old mission hospital in Africa, and I did a lot of obstetrics, and I came back training to be a GP, but I found that obstetrics was what I was really interested in, and in those days, before you could do your postgraduate exams, you were required to do an elective year. And to cut a long story short, I ended up doing that with Professor Howard Jacobs, who at the time was one of the leading endocrinologists in the world of reproductive medicine, and Bob Edwards, who of course got the Nobel Prize for the first IVF baby. So I worked in a clinic that was supervised by them. So that really inspired me, and,
Wow.
and the rest kind of speaks for itself.
Absolutely. Say no more. So, Adam, this podcast is aimed primarily at educating patients. So, for that reason, we try to avoid using medical terms so that it remains as accessible as possible to everyone. And I know that you yourself are very committed to education of patients. Let's start with the basics. The definition of a syndrome is a condition characterized by a collection of symptoms. What are the symptoms of PCOS?
So, Gail, you've said absolutely the right thing there, because many women with polycystic ovary syndrome have a range of symptoms, and not everybody has the same symptoms. And those symptoms can vary over time at different stages in a woman's life, and can be influenced by a number of factors. For example, lifestyle, changes in body weight, all sorts of things can affect the symptoms. So the three key things that we recognize are, first of all, some form of disturbance of the menstrual cycle, which means that women either have irregular periods or may have stopped having periods altogether. And again, that can fluctuate within an individual and over time.
Yeah.
Associated with that is a disturbance or an imbalance in hormone levels. So those are the chemicals that circulate in the body and tell the different parts of our body how to work. And here in particular, we're talking about the way the ovaries are working. And one of the main hormones that is imbalanced or is produced in excess by the ovaries is testosterone, which everyone will have heard of, and many people will associate as being, I say this in inverted commas, really a male hormone, but it isn't really a male hormone. All women make testosterone, because testosterone then gets changed into estrogen, which everybody considers to be the main female hormone, but in fact all men make estrogen as well.
Yeah.
So it's a relative balance of testosterone and estrogen. And for a number of complex reasons, women with polycystic ovaries seem to produce an abundance of testosterone, and that has a number of effects. It has an effect within the ovaries and affects the way the ovaries behave, and can contribute to the irregular or absent menstrual cycle. But also the testosterone circulating around the rest of the body can affect the growth of hair, so it can cause unwanted hair on the face and the body, and also for some women thinning of the hair on the head. And that will vary a lot from person to person, and it depends very much, for example, on ethnicity. Hair color, skin color can also affect the appearance of hair, and how much it affects an individual. The other thing that you can see is acne spots on the face and body. Of course, acne is very common during
Hmm.
adolescent years, and it's very common in all of us at different times, and so it's not necessarily always due to a hormone disturbance, but acne is another feature of having excessive testosterone. The third thing is the appearance of the polycystic ovary, which of course gives the syndrome its name. So the polycystic ovary essentially is an ovary that has a higher than average number of the tiny little cystic follicles, which are the structures that are naturally occurring and contain the eggs. So in a woman's natural cycle, a number of these little follicles start to grow each month and can be seen on an ultrasound scan. But the natural hormone levels only enable one of those follicles to grow and ovulate. So in a normal menstrual cycle, you'd expect to release one egg, and those other follicles just fade away. Because of the imbalance
Yeah.
of hormones that is leading to this disturbance within the ovaries, women with polycystic ovaries have a large number of these tiny immature follicles. They're usually only a couple of millimeters across, and we define a polycystic ovary as one that has at least 20 follicles in each ovary. And it's important to stress that these are egg-containing follicles. They are not large cysts that require surgical removal. I think the term cyst often makes people alarmed, thinking, do I need an operation? Are these cysts going to cause me harm? Are these cysts going to turn into cancer? Well, the answer is no. They're tiny, they're growing and fading the whole time, but just the imbalance of hormones does not enable one to grow and ovulate for most women with polycystic ovary syndrome who are having irregular periods. But irregular periods still means irregular ovulation, and even not having periods at all can be associated with occasional ovulation. And I think that's a very important message, because if you've got polycystic ovary syndrome and you may not be wishing to get pregnant, it's important to appreciate that you can still ovulate and could have an unwanted pregnancy unless you use appropriate contraception. On the other hand, if you are wanting to get pregnant, you may need some sort of support with different treatments, which I'm sure we'll come on to help stimulate regular ovulation. So, polycystic ovary syndrome comprises of polycystic ovaries seen on an ultrasound scan, some form of menstrual cycle irregularity, and some evidence of excess testosterone, either just by measuring it in the blood or the sort of symptoms I was explaining. And to have the diagnosis of polycystic ovary syndrome, you should have at least two of these three different components.
Okay, wow, that's a lot of information. So just to unpack that, thanks, that was so articulately put. Thank you. Just to unpack that a bit and kind of teasing out each individual thing. So you really made clear the point that polycystic ovaries does not mean that you have enormous large cystic ovaries. That's a really, really important take-home message. I couldn't agree with that more. As a In terms of the unwanted hair growth, so we all know there's a spectrum, like there's a spectrum of height and there's a spectrum of everything in the human race. And we do know you mentioned different ethnicities. So some ethnicities have more hair than others naturally, genetically. Um, the unwanted hair growth. So, for example, some women may think, oh, I've got hairy arms or legs. I have to shave my legs more often than another woman. Is that what we're talking about? Or is it hair growth in a particular area of the body? Can you just elaborate on that a little bit for us?
Of course, and I think that's a really important question. So, the key areas of the body that are sensitive to the excess testosterone are the face, often the chin, the jawline, or the upper lip. Those are common areas.
Hmm.
Sometimes
Hmm.
on the chest area, around the breast, sometimes on the abdomen. Hair on the arms and legs does not tend to be hormonally sensitive, but is more related to inherited distribution of hair due to your ethnicity or how things may be in your family, which is why when we come to talking about treatment to suppress the unwanted hair growth,
Yeah,
it will not
yeah.
remove the hair from everywhere, and even the hair that has started to grow excessively, maybe on the face, for example, won't necessarily completely
Hmm.
go away. It's natural to have some hair. The treatments that we
Yes.
provide usually suppress the growth and reduce um, the speed with which the hair will regrow.
Okay. Thank you. That's really clear. Okay, so are there any, you mentioned in passing that there are some factors, so there may be perhaps genetic factors or lifestyle factors, etc. I always ask about risk factors because sometimes risk factors we can't alter, like we can't alter our genetics really. However, there are some risk factors that we can alter and we can reduce the risk of having a certain condition or the extent of it. Are there any risk factors for PCOS? Can it be prevented or can it be ameliorated by lifestyle choices?
Definitely. So, I mean, the first thing is to take a step back and ask the question, what causes polycystic ovary syndrome? Which is a question I don't really want to answer
Hmm.
because we don't fully know the answer. And I
Hmm.
certainly believe that one woman's PCOS isn't the same as another woman's PCOS. I think there are a number of different routes to developing polycystic ovary syndrome, and we know that the seeds are sown when a girl herself is in her mother's womb. So even maternal influences whilst the baby is developing in the womb can actually lead to later effects on the way the ovaries work. Certainly, it runs in families. And if your
Hmm.
mother or sister has polycystic ovary syndrome, you've got about a 50% chance of having it as well. So it doesn't mean to say that every daughter of a mother with PCOS will have PCOS herself, but there's certainly a much higher chance of it occurring if you consider that the likelihood of PCOS in the general population is in the region of 10 to 15% of women, roughly speaking, and that will vary around the world. So, if it runs in your family, you're more at risk of developing symptoms, and
Yeah.
that may alert you to take greater care, perhaps as you're growing up, to watch your diet and your weight, because we know that people who become overweight are much more likely to develop problems, and that's all sorts of health problems in reality. But we know that being overweight can have a profound influence on the way the ovaries behave and a profound influence on the imbalance of hormones and can lead to a number of other consequences, such as the later development of type 2 diabetes and other metabolic problems that, again, I'm sure we'll come on to discuss. So,
Hmm.
so the main risk factor, I suppose, is if it's in your family, and the
Yeah.
main things that you can do to try and keep a healthy weight, which I can appreciate can be, it's easier said than done for many people. Um, but it really is key to the management of polycystic ovary syndrome and the effectiveness of any of the drug treatments or other treatments that wish to offer as well.
Okay, thank you. So my next question, you've kind of answered initially with your very comprehensive first answer. So I was going to ask, how is it diagnosed? So if you can just recap that for me so that it's clear, because there are girls or women who come along and say, oh, I've got a history of polycystic ovary syndrome. I say, okay, really? How was that diagnosed? It was diagnosed on a scan. So and then when I tease into what other symptoms there are, there aren't any other symptoms. They have regular periods, they have no unwanted hair growth, no acne, etc. But it was diagnosed on a scan. So can you just clarify whether that is, like a secure diagnosis, or can you just clarify again that the diagnostic criteria to make it really clear that it's not just a scan necessarily that can make that diagnosis?
Certainly. So, I mean, two key things really. First is that polycystic ovary syndrome is quite common and may coexist with other conditions, and that is other conditions that can result in unwanted hair growth or other conditions that can result in
Hmm.
an irregular menstrual cycle. So it's very important that the appropriate tests are done to make sure that it is polycystic
Yeah,
ovary syndrome and it's not something else. And also, having
yeah,
polycystic ovaries on a scan is quite common as well. And depending upon a
yes.
number of different scientific publications that you may read, some people suggest that 20 to 25% of women may have polycystic ovaries, and that may be seen without there being any symptoms. And the younger you are, the more likely you are to have more of these little follicles or egg containing follicles in the ovaries. And there's some debate as to when should you be diagnosed polycystic ovary syndrome in a young person, because many young, adolescent girls will have lots of these little follicles in their ovaries anyway, without necessarily having any symptoms of polycystic ovary syndrome. Um, but as you get past your teenage years, if you get into your 20s and you've got lots of follicles in your ovaries, I think it's safe to say that you've got polycystic ovaries, and if you don't have any symptoms, you just have polycystic ovaries without the symptoms. But it's still important to know, because if you were to become overweight, then the symptoms may start to cause problems. Or if you need fertility treatment and fertility drugs to stimulate your ovaries, even if it's not because you're not ovulating, those ovaries may respond in what we describe as a polycystic fashion. And so you need to take great care not to overstimulate the ovaries, because that can cause some women to become quite unwell. But coming back to the tests that we do, so if we have
Hmm.
a woman of any age in whom we think they may have polycystic ovary syndrome, the key tests to do are a measurement of testosterone in the blood, a measurement of the hormones that come from the pituitary gland. So that's a little gland in the base of the skull that produces hormones that control the way the ovaries work. And here we're talking about follicle stimulating hormone, FSH, and luteinizing hormone, LH. And they should ideally be measured at the time that somebody's having their menstrual bleed. So any time, ideally days 1 to 3 of the menstrual cycle, unless you're not having periods, in which case you can just have the test done at any time. So we measure FSH and LH, testosterone. I think it's helpful to measure estradiol, which is the chemical name for estrogen. And for women with irregular
Hmm.
periods, we would want to check thyroid function. So the thyroid is a gland in the neck, which can misbehave and affect the menstrual cycle. So it's important to check that that's okay. We also measure a hormone called prolactin, which is also produced from the pituitary. It's the hormone that's responsible for lactation. So when a woman is breastfeeding, prolactin is important, but high levels can occur at other times for other reasons and can sometimes affect the menstrual cycle. So those are the key things that we do to help make the diagnosis. if the testosterone is significantly elevated, we may want to look at some of the other related hormones known as androgens. So testosterone is an androgen, and testosterone and the other androgens are produced by the ovaries and also by the adrenal gland, which is a little gland that sits on top of the kidney. And rarely in the UK, some women with high testosterone can have other causes of overproduction due to abnormalities in the way the adrenal gland works, which I don't think we need to go into. But if the testosterone is very high, we may do some additional androgen tests. Um, Similarly, if a woman is overweight and is thought to have polycystic ovary syndrome, it's worthwhile doing some additional screening tests, for example, to rule out diabetes or early onset or type 2 diabetes. So there are various screening tests that can be done to measure um, HbA1c, which is a sort of a way that we can assess long-term sugar levels in the blood. May want to look at
Yeah,
kidney function, liver function, check that the individual isn't anemic. Iron levels and being low in iron and being nutritionally deficient can be associated with loss of hair on the head, as can a condition called celiac disease, where you have um, um, a sensitivity to gluten, which is contained in wheat and some other cereals, and can affect absorption of vitamins. So, some women who have thinning of the hair on the head may have other reasons. It's not necessarily due to polycystic ovary syndrome, even if they have features of polycystic ovary syndrome. So, what I'm trying to say here is the key things are the high testosterone and the polycystic ovaries, but those
yeah,
other hormones that I've listed will help exclude other reasons for menstrual cycle disturbance, of which there's quite a long list.
quite a few. Yeah, yep, yep. So I always I tell my patients that the periods are often the first thing to go awry if there's any issues in the body. So like if the thyroid is off or whatever, the periods will go off. Many things, weight loss, weight gain. Periods are so them in themselves. Irregularity doesn't point to a particular diagnosis. It means it's an indication that we need to rule out, as you just said, several possible diagnoses in order to reach the actual diagnosis that's appropriate. So I guess the take-home message there is don't assume and go along. If you have these symptoms, go along so that the appropriate investigations can be performed. And another really important thing that you've just said is that the blood tests need ideally to be done when a woman is on her period so that they can be appropriately interpreted unless she's not having periods. Because a random blood test throughout the cycle is much more difficult or impossible to interpret. Do you agree with that?
Yes,
Because that's an important piece of
yes,
knowledge, I
yes. That's
think.
right. That's right. I mean, one thing that
Okay.
GPs often think about is they have in their head day 21, because when we're at medical school, we're taught that the best time to measure
Yeah.
a certain hormone, and that hormone is progesterone, that tells us whether you've ovulated, should be measured on day 21. In reality, it should be measured about 7 days after ovulation, which is day 21 on a 28-day cycle. It may be day 28 if it's a
Hmm.
35-day cycle, for example. So many GPs, of course,
Yeah.
GPs have to think of all sorts of things, and so can't be expected to be experts in every aspect of medicine, but they will
No,
they will
absolutely.
remember day 21 and may send you for a blood test on day 21 to measure all of your hormones, and that can cause huge confusion because it can be very misleading. So what I often say to my patients who are maybe having irregular periods, or they may say, oh, I'm having a period every 2 to 3 months, but I want to know what's going on. I may do a blood test today in the clinic to see what's happening with the hormones today, and give them a form to go away and say, if you have a period before I see you next, try and get your blood done whilst you're menstruating, because that will be useful as well.
Yeah. 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 Absolutely. Okay. And Is the time frame between symptoms to diagnosis important? Is there any relevance? So if a woman has symptoms, some of the symptoms you're describing, is it imperative that she goes along really quickly to obtain this diagnosis? Or do you think, you know, it's not, there's no particular risk. There's no, it's not urgent. It's not like, postmenopausal bleeding, that's urgent. You need to go along for that as quickly as possible. Is there a significance, within reason, to going along quickly, or can you be pretty relaxed about it?
I'd sort of take a halfway house approach really to that. So it's not cancer. You don't need a diagnosis in a week or two, but you still do need to know what's going on. I think everybody has a right to have a swift diagnosis and to know what's going on. So if you have any concerns, don't be frightened to ask your GP. And if your GP doesn't feel comfortable checking things out for you, ask to be referred to a reproductive specialist like myself, or like you, Gail, just to be checked over, because there are some consequences. Certainly, if you're having long gaps between your periods, the lining of the womb. So the lining of the womb is called the endometrium. The lining of the womb can thicken over time, and sometimes it can develop abnormal changes or even develop into a cancer of the lining of the womb. That usually only happens if you haven't had a bleed for many, many months, but nonetheless, it's important to get checked out and important to be provided with some form of treatment that will initiate shedding of the womb lining to prevent it from becoming abnormally thickened. Because once that process starts, it's difficult to reverse, and it may have a long-lasting effect on the way the womb behaves and on the ability to conceive in the future. So it is important. So if your GP says to you, I wouldn't worry about not having periods, just come back when you want to start a family, that's not the correct advice. It is important to be given something to enable the lining of the womb to be shed on a regular basis. So we're beginning to talk about treatments now. So I suppose whilst we're talking about this, I might as well say, how do you do it? How do you ensure that the lining of the womb is shed regularly? Well, there are a number of different ways. The hormone progesterone that we mentioned before, that's produced after ovulation, actually also can help with the shedding of the endometrium. So you can just give progesterone once a month or once every 3 months for 7 to 10 days. I usually give 10 days, and that will uh, achieve shedding of the womb lining and prevent it from becoming too thick. So progesterone's the key hormone there. We often find that we're prescribing the combined oral contraceptive pill, which contains both estrogen and progesterone, and that can provide an artificial cycle and again enables the womb lining to be shed, but suppresses the production of testosterone and actually helps mop up testosterone. So there are a number of different pills on the market. The ones that have less of the of the sort of what we describe as androgenic or testosterone-like progestogens. So I'm sorry to use some technical language here, but the best sort of contraceptive pills to use are the ones that contain the sort of the milder progesterone preparations.
Mhm.
And you can take that either in a monthly cycle, or some women run the packets together 3, 6 months, or even longer. And that successfully suppresses the overproduction of testosterone and should help improve the symptoms of testosterone excess, like suppress the unwanted hair growth, which can take many, many months to start to improve. So you're basically ticking a few boxes here by both suppressing testosterone and the symptoms of testosterone excess on the hair and the skin, but also protecting the lining of the womb from becoming abnormally thickened. So that's the combined oral contraceptive pill, which is a very common way of managing the symptoms of polycystic ovary syndrome. Some women aren't able to take the pill because they're overweight, or there may be other reasons why it's contraindicated. For example, if they have migraine or very, very
Yeah.
high blood pressure, in which case you can protect the womb lining either by just giving progesterone on its own, or using a mini pill, which is a progesterone only pill, although that won't help the hair problems, or you can use a progesterone releasing coil that can be put into the womb that again can help prevent the overgrowth of the lining of the womb. So there are a number of alternatives if the combined pill isn't able to be used.
And is there any minimum number of periods a woman needs to have per year, for example, that she needs to be
Yes,
on one of these treatments?
yes. So ideally, I think the womb lining should be shed once every 3 months or so, so at least 4 menstrual bleeds a year.
4 periods a
Yeah,
year.
unless you're on a treatment that is suppressing your cycle, in which case you don't have. So often we say, oh, you need to have 3 or 4, a bleed every 3 months or 4 periods a year. And then you give a treatment that suppresses bleeds altogether, and then that can cause worry because it's a
Yes.
common question. Well, shouldn't I be having a bleed? So you have to again
Right.
use that as a caveat that if you're on some sort of therapy, you may be protected anyway, even if you're not having bleeds.
Yeah. So the 4 periods a year is only on your own steam if
Yes,
you're not
yes.
taking any hormones to
Hmm.
influence that or
Hmm.
suppress periods in
Hmm.
themselves. Okay, perfect. And so you started on treatment. Let's carry on then. Um, so what treatment options are there, and how effective are they? And I guess that depends on which particular symptoms you're having. You alluded to that earlier. Not all women have the same exact collection of symptoms. For some, it may be unwanted hair growth. That's the significant symptom. For some, it may be periods. For some, it may be fertility. So, can you give us kind of a whistle stop tour through the treatment options? Shall we start with maybe unwanted hair growth? You mentioned about the pill
Yes. Okay.
and mopping up the testosterone levels, etc.
Well, I'll take a step back and just,
Are there any
yes,
other
I'll take
options?
a step back and just say, sort of, for all women with PCOS, irrespective of symptoms, uh, the first thing is to consider is lifestyle. You know, focus on maintaining a healthy weight. So your body mass index should ideally
Yeah,
be within the normal range. Um, More fat
yeah,
around the sort of tummy area can be detrimental as well. So lifestyle is important. There's lots written about diets for polycystic ovary syndrome. I don't believe there is a PCOS diet. Um, the diet that is useful for you or that works for you is the one that's going to be achievable and sustainable long term. It's important to keep sort of
yeah.
carbohydrates low as a general rule. Um, but exclusion diets or protein only diets don't work in the long term. So it has to be a balanced diet. You may benefit from the advice of a nutritionalist. And also, what I didn't mention in the testing, but we certainly do, is measure certain vitamins like vitamin D, for example, folate levels, iron stores. Those are important. Um, I'll give a little plug here. This is a good time to bring in my book, which I wrote with my partner and colleague Grace Dugdale. So, the fertility book. It's not only about fertility, it's about all aspects of reproductive health. There's a lot in here about polycystic ovary syndrome, and there's a lot in here about diet and supplements. And so that's
Okay.
that's that's the first thing, and that will help influence your response to treatment, whether it's unwanted hair growth or whether you're trying to get pregnant. So, first, when we're thinking about the unwanted hair growth, it's okay to remove the hair by physical means, and some women shave or wax, and it's a fallacy to think that that causes the hair to regrow more quickly. It's not true. Um, so, whilst I appreciate that most people don't like to shave, there's nothing wrong with shaving, plucking, or waxing to get rid of that unwanted hair. As far as the treatments, as I mentioned, hormone treatments, we usually start with the pill. whilst all hormones have some side effects, the pill is probably the most tried and tested and probably the pretty much the safest. But if you can't take the pill, there are um, other medications that suppress testosterone or help mop up testosterone. Spironolactone is a drug that we often use. Occasionally, we use a drug called finasteride. They should only really be prescribed by a specialist in a clinic like ours and need to be monitored. And you shouldn't get pregnant whilst taking such drugs because they can have an adverse effect on the developing baby in your womb. So those are different approaches. Other physical means of removing the unwanted hair, either electrolysis or laser, not often available through the NHS, so it can be costly. Nothing's 100%
No.
curative, and there are pros and cons of each, and it depends upon skin color also as to whether or not laser may be suitable. So there are other ways of dealing with the unwanted hair. There's also a topical ointment called Vanica, which is the commercial name for eflornithine, which um, can be helpful, but it's expensive, and GPs don't tend to prescribe it. So those are the main things really when it comes to the hair and skin side of things. I'm not a great fan of antibiotics for acne. Lots of adolescent girls are put on antibiotics long term, but that can affect the natural balance of bacteria in your gut, the microbiome, and it can cause all sorts of long term problems. So, if you've got polycystic ovary syndrome as the cause of your acne, it's because of a hormonal imbalance, and therefore, I think the hormonal side of things should be tackled. Um, if you are overweight and have signs of possibly developing diabetes, or even if you have diabetes, you'll need treatment for the diabetes. One of the most commonly used drugs is a drug called metformin, which has been studied a lot in polycystic ovary syndrome. We've done a lot of research in Leeds on metformin. It can have a place, it can help some people, but on the whole, it has a limited benefit. And there are other supplements, for example, inositol, which can also help with the metabolic side of things. Maybe we should come on and talk about that in a minute. But so there are
Hmm.
supplements that can be beneficial as well. But again, the evidence isn't very strong, and I think it's a multi-pronged approach. Lifestyle supplements, and then finding the right sort of therapy, and having long-term support and monitoring really.
And in terms of the pill, have you any opinion about, for example, using Dinette, which has cyproton acetate, versus another form of pill? Some people seem to think that, you know, all pills will lower testosterone, all combined pills. But some people think, well, if hirsutism and acne is, a prominent feature, that maybe a even initially to be placed on Dianet is beneficial. What are your views on that?
So we've used Dinette for many years. It's got quite a high dose of estrogen in it. And interestingly, the evidence is that it doesn't seem to be any better than other pills. So, any low dose combined oral contraceptive pill. So, I'm a great believer in using the lowest effective dose. There are some pills that have these anti-androgens in them, um, and yes, they
Yeah.
can be effective. And again, I have many patients who've been on Dianet for years and years and years and swear by it and think it's wonderful. In which case, great, continue with it. Um, but for an adolescent girl with PCOS, I might start on one of the sort of the lower dose combined oral contraceptive preparations. There are a number of them, but one that contains 20 micrograms of the estrogen rather than the 35 micrograms that you find in Dianet.
Okay. Um, and are there, so I think that probably covers standard treatment options. Um, Looking more long term, are there any long term issues associated with polycystic ovarian syndrome? So, if someone has a diagnosis, then and it is maybe well controlled, so their periods are controlled or they're placed on the pill, etc. Are there any long term issues that they need to be aware of? And this is maybe another, like you mentioned, another important reason why going along to have the diagnosis made is important, because again, you may be able to modify your life and modify your risks or screen or whatever the case may be. What are the long term risks, if any?
So we've talked about the lining of the womb, the endometrium, and the potential risk of developing cancer of the lining of the womb if it's not properly managed,
Yeah,
but we've covered that. So the other
yeah.
main risk is the risk of developing type 2 diabetes and possibly also cardiovascular disease. And that's because of the association with being overweight, um, which leads to an upset in the way the body handles sugar, um, and a condition we refer to as insulin resistance, which essentially is when your body does not um, recognize insulin properly. Insulin is a hormone that's produced by the pancreas, which sits by the stomach and is released in response to food. So when you have a meal, your body produces insulin and other hormones from the gut that kind of deal with the nutrition that's coming in and helps send that nutrition to the right parts of your body, for example, into your muscles where carbohydrates such as glucose are used for energy, because we need to have glucose and
Hmm.
carbohydrates in order to function. And the way insulin works to enable glucose to enter the cells in the muscle is it acts through a receptor. And the easiest way to picture this is the receptor is a lock in a door that is unlocked by insulin to enable the glucose to enter the muscle cell, where it's essentially the fuel for uh, energy in the muscles. But when there is insulin resistance, which again can be inherited, and certainly begins to occur in people who gain weight, when there's insulin resistance, the lock becomes rusty, so the insulin doesn't work properly. So you have higher and higher levels of sugars circulating in your blood because it doesn't get into your muscle, and
Hmm.
that sugar has to end up somewhere. Um, and so you basically have a metabolic disturbance. You have a disturbance in the deposition of fat in your body as well. So you can get excess fat building up around your tummy, under your skin, in your liver, can affect the circulation, so it can affect the lining of your blood vessels. And the body then starts to produce more and more insulin to overcome this resistance within the
Yeah,
cells. And the higher levels of insulin, interestingly, then have an effect on the ovaries, because insulin causes the ovaries to overproduce testosterone, because the receptor or the lock for insulin in the ovary is very different. And again, I'm not going to go into any greater detail, but the bottom line
yeah,
is high levels of insulin in women with PCOS who are overweight exacerbates the production of testosterone by the ovaries. So you then get this vicious cycle and the whole thing is amplified. So testosterone from the ovaries is stimulated by insulin. It's also stimulated by a hormone we mentioned earlier called LH, luteinizing hormone. And we tend to find that slim women or normal weight women with PCOS tend to have high levels of LH that's stimulating the testosterone, and women as they become overweight have high levels of insulin that stimulates the testosterone. And so if you can get those insulin levels down, either by losing weight, preferably, and sometimes by using medications such as metformin, that can help improve the situation. So the longer term effects are that you develop diabetes. So diabetes is when you have high levels of sugar in your blood long term, and that leads to a whole
Mm.
load of consequences that I began to allude to, um,
Yeah.
and may be associated with increased illness as you get older, um, and possibly also an increased risk of dying from certain conditions, although interestingly, there are other components of PCOS that may help protect against certain long-term conditions. So it does get a little bit um, tricky here, sort of teasing it all out. But the bottom line
Right.
is, if you keep a healthy weight, you're less likely to run into these problems. If you become significantly overweight and you just can't lose weight, sometimes we resort to there are some new drugs which are injectable, which are used for the treatment of diabetes that can help with weight reduction, but that has to be carefully supervised and managed in a specialist center. Or some people even end up having bariatric surgery, which is either gastric banding or gastric bypass, where a band is put around the stomach. So that's an operation to restrict the capacity of the stomach, or to sometimes to bypass or remove some of the stomach, and that's done by that's done by a specialist surgeon, but that can have a profound effect on enabling weight reduction and a reversal of things like diabetes. So yes, there are
Okay.
long-term
And
consequences, and mostly
indeed.
associated with being overweight. And that also has an effect on fertility. So we haven't talked about fertility treatment yet, but being overweight, even if you get pregnant, will lead to an increased risk of miscarriage, an increased risk of having problems in pregnancy, both for yourself and for your baby. So it's all about having a healthy baby. And I mentioned earlier on that the baby in the womb is influenced very strongly by the health of the mother. So that's whether the baby is a male or female. So
Yeah.
the the time that a baby's in the womb actually has a lifelong influence on the long-term health of that baby, infant, child, and future adult. So anything you can do to be as healthy as possible will minimize the risks both to you and to your baby. The risks to you in pregnancy of being overweight, of developing um, pregnancy-related diabetes or blood pressure problems,
Blood
number
pressure.
of other
Mm-hmm.
things that
Mm-hmm.
can be an increased risk if you're overweight. Um, if you're
Okay.
having irregular periods or not having periods and you want to get pregnant, then again losing weight is really important, because the drugs that we use to stimulate ovulation really don't work very well in women who are overweight. So there are a number of drugs we usually start with tablets. The main tablet that we use is a drug called letrozole, which has taken the place of a medication that many people ask about called Clomid or clomiphene, which certainly does work well in stimulating ovulation, but letrozole works better. So that's what we would usually use as a first line treatment. So that's a tablet. It has to be monitored with ultrasound. If it's working, great. If
Yeah.
it isn't working, then we can give hormone injections, which again has to be very carefully monitored. Or occasionally we do a surgical procedure called ovarian drilling or ovarian diathermy, which can kickstart ovulation, but it's only a treatment that we use for women who are wanting to get pregnant. It's falsely considered by some to be a cure of polycystic ovary syndrome. It isn't. It's just a one. It's an alternative fertility treatment that, in reality, isn't performed a huge amount these days in the UK, but can be effective in the when provided to the right person.
Okay. And so, assuming, for example, if an adolescent girl is diagnosed as having polycystic ovary syndrome, a really prominent worry often is that of fertility, or even an adult woman, how soon would you encourage them to not panic about it because there are effective treatments? And even an adult woman who is trying to embark and wants to start a family, would you say, well, try like anyone else? I suppose it depends on age to an extent. Would you say try for a while first, or would you say get down to a fertility clinic because you're really unlikely to conceive spontaneously?
Most women with polycystic ovary syndrome end up having children, not necessarily always the number of children that they may wish. Um,
Okay,
but if you know you've got polycystic ovary syndrome, I think you should seek help straight away. And the reason for that is that
perfect.
fertility goes down as you get older. It can take a while to access fertility services. I mean, we're still suffering with the sort of the fallout from COVID, and um, we
Yeah,
have a big team here in our clinic, but we still have a long waiting list for appointments, unfortunately. So, whilst you're waiting, read my book. That's the first thing, because you can be doing things yourself. So you have to take the
yeah,
initiative. Don't be fobbed off by your GP if your GP won't refer you. Say, I know I have a right to be referred. I want to be referred. And if you get pregnant whilst you're waiting for your clinic appointment, that's brilliant. But
fantastic.
but
Yeah,
so whilst you are waiting to be seen, address your lifestyle. Make sure you're taking the right supplements. If you're trying to get pregnant, that includes folic acid, which is important for the developing baby. Vitamin D as
yes,
well is important.
yeah,
And um, so the answer is yes. You need to be linked in
yeah,
to a reproductive medicine clinic who's used to managing these sorts of problems and providing treatment that's appropriately monitored. And by appropriately monitored, that usually means having the ability to provide ultrasound scanning of the effectiveness of the drugs that are being used. That's really important, both in order to see that you're responding properly, but also to ensure that you're not over responding, because the risk of the treatment is either multiple pregnancy if you produce too many eggs, which can be very dangerous.
yeah,
And so that's why
yeah,
things need to be monitored. Or sometimes this
yeah,
condition I alluded to earlier, called ovarian hyperstimulation syndrome, doesn't often happen with just trying to stimulate ovulation. It happens more if you need IVF. Now, IVF is not a treatment for polycystic ovary syndrome until all of the other options I mentioned have been exhausted. So it's wrong to go straight for IVF unless there are other fertility issues.
yes,
So if your partner's got a low sperm count, or if you've got blocked fallopian tubes,
yeah,
then IVF may be required. But if you've got polycystic ovaries and you need IVF for whatever reason, then you're more at risk of ovarian hyperstimulation. And again, the protocol that's used to stimulate your ovaries has to be tailored individually to ensure that those risks are minimized for you.
okay. So it sounds like that there is effective treatment to assist women with polycystic ovary syndrome to conceive. So that's
Yes,
brilliant.
yes,
So we can reassure them
there's
that,
effective treatment, but it can take a bit of time. Doesn't work.
but it can take a
Yeah,
bit of
doesn't
time.
work for everybody, and that's why it's important to link in and not to leave it too late either.
Yeah, yeah, absolutely. Okay, brilliant. So thank you for those brilliant and clear answers to my questions. As you know, I'll ask listeners beforehand to submit questions that they'd like me to ask on their behalf. Would it be okay for me to ask a couple questions from our
Sure.
listeners? Is that okay? Great. So I must stress at this point that it's very difficult to give specific and personalized advice to patients without a thorough knowledge of their past and current medical history, examination findings, etc. And also, due to time constraints, I've summarized the questions in a way that I think retain the essence of what is being asked. Therefore, these answers should only be used as a guide, and individualized care and medical management should be sought from one's own doctor. So, our first question is from a mother of a 15-year-old. She says that my 15-year-old is having a horrendous time and her quality of life has changed beyond recognition due to PCOS. Which oral contraceptive pill, if any, is most beneficial for teens with polycystic ovary syndrome? I think you kind of answered that
I
already.
kind of answered that. I mean, I'd say I usually use a 20 microgram preparation with desogestrel or gestodine, so the sort of drugs, Gederel, Mercilon, Femidet. Those are the sort of the brand names. We probably shouldn't be saying too many brand names. There are a number that are sort of similar. Um, but that's what I would
Yeah,
usually use. Now, obviously, will depend upon her body weight as well. If she's very overweight, that needs to be addressed
yeah,
also, and she might need a higher dose. It all
yes,
depends, because I appreciate it can be, hugely disruptive during teenage years, can affect schooling. I mean, period problems aren't only due to
exams, yeah,
PCOS. I mean, many adolescent girls have period problems and all sorts of difficulties with their menstrual cycle. And again, the fact that there are polycystic ovaries seen on scan doesn't always mean that they've got polycystic ovary syndrome. And we usually say you can't really make a firm diagnosis until at least 3 or 5 years after periods have started. Some people even say you should wait a little bit longer than that. So I think it's managing the periods that's important. And alongside that, and I think it's really key to ensure that that vitamin supplements should be used. If you've got a girl with heavy periods, iron, folate, vitamin D, that's all really important. Um,
yeah,
Many adolescents have disturbances in their eating patterns, sometimes even disordered eating, whether that's bulimia or anorexia. So, we have to sensitively try and sort of find out whether there may be any such issues going on, and they often coexist also with polycystic ovary syndrome. So, as I was saying earlier, PCOS is common, other things are common as well. They often coexist, and so you need to ensure that
indeed.
everything is covered.
Yeah, brilliant. Very thorough answer, thank you. So the other question she asks, and this is really interesting actually. She said, what other treatments are available to help manage symptoms of PCOS, such as severe fatigue and pain?
Well, so severe fatigue, as I mentioned, it could be just because she's low in nutrients or vitamins. So looking at that and
Absolutely,
and
vitamin
and
deficiency.
taking the advice of a nutritionist. I mean, that's not sadly available routinely through the NHS. Again, take a look at our book. It's got that sort of information in it, irrespective of your age. Seek the
Yeah,
advice of an experienced and appropriately qualified nutritionist as well. As far as pain is concerned, it depends. Where is that pain? Is the pain associated with the ovaries or the womb? In which case, taking the combined oral contraceptive pill continuously, or some other form of medication to suppress menstruation, which may even be a long-acting progestogen type contraceptive such as Depo-Provera injections or implants will suppress menstruation. And if the activity of the ovaries or the womb is all sort of quietened down, that will often help with pain. But pain isn't only due to, doesn't only come from the ovaries and the uterus. Pain can be from the bowel, so make sure diet is normal, that bowels are regular. Um, uh, I think it's very important to ensure that diet, bowel function are as normal as possible, and look for other other causes or other problems if there are significant bowel problems.
absolutely. So I think that question actually encapsulates something that you've mentioned before in this interview, in that actually sometimes it may be worth going back to square one, making sure that that diagnosis is correct actually, because pain, when you listed the symptoms of PCOS, pain wasn't one of them. There are many causes of pain. There are many causes of irregular bleeding, acne in teenagers. So it may be worth just revisiting that diagnosis, because the symptoms she's having, severe fatigue and pain, maybe something different
Yes,
altogether.
and there's another condition called
Is that,
yes,
do you agree with
yes,
that?
and endometriosis you can see in adolescents, not that commonly, but that can
Yeah,
cause
absolutely.
pain. So, that
Yeah,
we have to, as I said, make sure that even if there are features of PCOS, don't forget that there may be other things as well that
don't assume that everything is
need to
down to
be
that.
ruled out.
Yeah, yeah, brilliant. Okay. And one more question from listeners, short one. And again, you've touched on this before. This listener would like to know what your thoughts are about starting metformin earlier in the treatment. So, thoughts on metformin early in the treatment. Is it a kind of last resort option, or do
Yeah,
you use
I
it
don't use it much.
as a first line?
I
Hey?
don't use it very much really. I only use it if there's signs of insulin resistance or impending diabetes. Uh,
Okay.
Sometimes it can help kickstart an improvement or a loss of weight. Sometimes not very. Doesn't have a major effect. Lots of people come along asking for metformin. It was thought to be the sort of the panacea and the answer to everything, but sadly that's not the case.
Yeah, it's not panned out. Okay. Okay. So, finally, Adam, you've seen and managed many, many patients with PCOS of various ages and with different issues. Given the opportunity, is there anything you'd like to say to patients who think they may have PCOS or perhaps have been diagnosed with PCOS?
So
Any messages?
yes, I would say first of all, if you're worried, seek medical advice sooner rather than later. Don't be fobbed off. Ask to be referred to a specialist. If you feel your GP, many GPs are knowledgeable and can manage things without you needing to be referred. But if you have any concerns, ask to be referred sooner rather than later. Make sure that you get
Mm-hmm.
advice from validated sources. There are lots of people out there claiming to be experts who may not have the training or the backing or the qualifications to provide expert advice. And the new world of
Yeah.
social media. I appreciate this is on social media, but there are lots of people
Yeah.
with websites and uh, who claim to be hormone experts who may not really truly be hormone experts. And I frequently see patients who've been given inappropriate advice. So that's something that I think is very
Yes.
important. And validated advice on the internet can be found through Verity. Now, Verity in the UK is the National PCOS Support Organisation. So they have trusted advice on their website. So that's Verity, Verity. And then there are other
Okay.
organisations such as the British Fertility Society, the Royal College of Obstetricians and Gynecologists, which are the professional organisations that will have information for patients on their website. And then the other big organisation for people with fertility problems is Fertility Network UK, which is the largest patient support group for people with fertility problems in the UK. And they again have lots of useful information on their website as well. So it's easy to get bamboozled and do a Google search and see all sorts of things that won't necessarily apply to you. And as we said at the very beginning, polycystic ovary syndrome is a syndrome, which means it's a constellation of signs and symptoms that can vary from person to person. So you may not necessarily see everything that applies to you on the particular website that you're looking at. And so it's important to get an individualized
Absolutely.
assessment by an expert who knows what they're talking about so that they can actually make sure that you're put on the right track and also have the right information so that you can um, you know, take control of your own symptoms. And I think that's the key thing, is to know what you can do yourself to take control of your symptoms and manage things, because it's your body. You need to be able to call the shots and make sure things are working for you.
Perfect, great. So I will, thanks for those signposts, and I will put them as links at the bottom of this podcast, as well as the information about your book as well. That's really useful. Thank you for that. So in closing, Adam, I can't tell you enough how grateful I am to you for coming onto my podcast, supporting my podcast, giving your valuable time and your expertise today. Thank you so much. And thank you above all for your hard work for all these couples with fertility issues and your dedication in the field of reproductive medicine and, in particular, polycystic ovary syndrome. Thank you so much.
Thank you. It's been a pleasure. Thank you.
Thank you for listening. I hope you found it useful. Please keep your eyes and ears open for upcoming episodes. If you enjoyed this, please hit the like and subscribe buttons to raise awareness of this podcast.